Oh, no, here.
That needs to be put away. Maybe we need to be working on our vent checks now. You can have a few minutes at the end of class. There's one right there in front of you. Everybody's got one, right?
Yep.
Okay. So today we're talking about doing a vent check. Oh, I just know what yours is right up there.
You should keep the first 30 seconds on the recording. Best part.
Okay, and Desiree is nice enough to record this little session, so she's going to post it on YouTube for everyone. So the vent check sheets are going to look different no matter where you're at. Some are going to still be on paper, some are on the computer. But what matters is the information that goes on there. That is the same. You just have to find where it is on the form. Just like finding a button on a ventilator, find where the information is on the form. Generally, you're going to have, we talked about having set parameters, patient parameters, alarms, and waveforms. Guess what you're going to have on a vent check? Not waveforms, but set parameters, patient parameters, and alarms. So that's the reason why I said what I did. So at the beginning of your vent sheet, you'll have your date, your time. Oh, and by the way, this is going to be your working vent sheet for you guys to refer to if you have questions later. Don't come back to me later and go, what does PS stand for? That's why we're doing this right now. So make sure you keep these, make notes, and keep it. You'll get blank vent sheets to use in the future, so you can have this as your reference sheet for what all this information is and what it means. Okay? So at the top of any vent sheet, you're going to have a place for your patient's name, maybe their MRN number, the time, what kind of ventilator, their ET tube size, and location. When you mark location on an ET tube, how do we know where it's at? Number at the lip, number at the teeth. Number at the teeth or gums if they don't have teeth. That never changes. Lips can get swollen, or like, am I going to say I'm 22 here or am I 22 here? Everyone, that's very subjective onto where it could be. The teeth and the gums won't change, so you should always mark it that way. So we might say 22 at the teeth or 22 at the gums. And that way when you're doing your next vent check, you guys should all pretty much have it the same unless there was an order from a doctor to move it back or move it forward. If you're supposed to be at 22 and you come in and it's at 25, that is something that you should be looking at. So, and then a lot of times there will also be sections on there for, is there an ambu bag with mask in the room? If the patient has a trach, is there an extra trach in the room? Things like that. Your first vent check of the day, you should also be looking for, make sure your ventilator's plugged into the red outlet. And I may, by other campus, I actually made pretend red outlets. I put little red things so you can just get in the habit of making sure it's always. Why do we need to plug it into a red outlet?
The power goes out to the generator.
Yeah, those are the outlets that are powered by the generator. So, yep. So you always want to make sure you got an ambu bag with mask in the room. I know from some of you, you've already seen that that's not always the case. The RTs will go, yeah, there's a mask. And the student will go, no, there's not. So, very important. Also, if just as a side note, if you go on a transport, you never, ever, ever go without a mask. Don't ever think a patient can't get intubated en route to somewhere, because it's actually fairly easy. And the last thing you want to do is be transporting somewhere to somewhere and then get extubated and you not have a mask. I can promise you can be in your director's office. And hopefully that patient won't die. So that's very serious. I've been with patients that extubated themselves en route to somewhere. If you haven't transported a patient on a vent yet, which I know some of you haven't even been in the ICU, you're going around curves, you're trying to get in the unit. And Mike, you had one, you were like practically standing on top of the bed. It's very,
I was.
So anyways, so okay, so that's the top section. Now the next section we're gonna do is set parameters. So mode is gonna be the mode that the patient's in. What are some examples of the modes that we've talked about? ACVC, ACPC, SIMV. Sometimes patients will be just on pressure support. That's what goes there. Mandatory respiratory rate is the set rate on the ventilator. So right now this one's set at 15. So 15 would go there. And we're in ACVC, so we would put ACVC. We're in volume control, which is ACVC. Tidal volume, set tidal volume. If you're in a volume control mode, you're going to have a number here. We're set in volume control, so we're at 450. If you're in pressure control, are you going to have a VT? No. You leave it blank? No?
Was that a question?
Yeah.
Or is that a
Do you leave it blank?
no?
No, you put a
No.
line on it.
What?
You might put a line across.
Put a line through it or NA. Never leave anything blank. If you leave something blank, it makes me question, does something belong here and they forgot to put it. A line through it or an NA, I know you accounted for it and it doesn't apply.
So even when you're charting in a computer, because
I know they don't do it in the computer
Yeah.
charting, so
it's possible.
I don't know if it's possible
Yeah.
either.
I don't know if you can even write like stuff. like
I
that.
don't
It has
think
to
you
be
can. On the
numbers.
computers, it would be different.
Yeah.
But paper charting, you definitely need to.
A lot of them, depending on what you set it, it'll already have the parameters
Yeah.
for it. You know what I'm saying?
And sometimes they'll even be shaded out and you know that that's not a possibility then. And you'll also learn too, oh, I'm in pressure control, I don't need to look for a tidal, I'm not gonna have a set tidal volume.
Yeah.
PRVC, would you have something in here?
Have
Remember we talked about
your limit, right?
Pressure regulated volume.
your limit?
Your peak? Or, I don't know.
We're talking about volume right now,
Oh,
tidal volume.
Yeah, you would.
Your max, your target tidal volume would go there.
Hmm.
So, PC stands for pressure control. So if we're in pressure control or PRVC, our max pressure will be listed here. So if we're in PC of 20, that would have a 20. If you're in volume control, it's an NA if you can, or a line through it. If you're computer charting, you just move on. PS stands for pressure support. Maria, if we're in ACVC right now, can we have pressure support? Yes, no, you're covered either way.
No,
Why not?
because it's assisting. It's not
What is pressure support for?
the pressure that's being given to the lungs.
Yeah,
Open.
but what kind of breath?
Spontaneous.
Spontaneous. Pressure support will only be on a spontaneous breath. So remember, in assist control, what happens when our patient initiates a breath?
Did you say assist
Then
control?
We're in
Then
assist
it
control.
cycles on.
It'll
It's
deliver.
cycle, yeah, it'll deliver the
Triggers
set
it.
volume or pressure. So there is no breath to even use pressure support on. So we would be saying NA. Pressure support can only be in SIMV or just plain old pressure support. Okay, TINSP, inspiratory time. Sometimes you'll see it as I time. Sometimes you'll see it in seconds. Sometimes you'll see it in percentages. But that's where you'll put your set I time. And then inspiratory rise time. The rise time is typically on a pressure control breath, and it has to do with, so this is our I time here. You guys see that? Yeah, I know, sorry. This is our I time here. Rise time is this. How quickly do I get to this? This is rise time.
What did it say on ours? Ramp or?
Ramps, yeah, same thing.
What was the other one?
The rise time is also,
Square and ramp?
Square.
no, that's your flow waveform. Ramp is sometimes called a rise time though. It's how quickly is it going to ramp up to that pressure.
Okay.
Square would be the flow pattern though.
I thought us changing it delivered it like gradually rather than just like all at once.
That's true, it will change it. I'm just saying that it will change it. There's actual setting to set the actual rise time.
Can you guys see that? Sorry.
Okay. Yeah, got it.
So rise time is also called slope, ramp,
Slope.
P ramp, I think, and then rise time percent. So when you're on the different ventilators, it's going to have different names. But it's all the rise time, and it all has to do with how quickly we get to that set pressure. That's usually patient comfort. If you see your patient is doing this, caving in, that means he's not getting it fast enough and you would need to increase it.
Sure.
Anytime you see concave, it means the patient's not getting enough flow or whatever. So that can be adjusted based on patient comfort. If you see it going high before it starts, like overshooting, like that, I know, that means it's too fast. So you want it to have a nice rise up and then over, which we'll get into more. I just want you to understand what rise time is for right now. All right. And you won't always have rise time, so that's one that sometimes might be NA or a line through. Peep, peep is peep. The set peep goes here. FiO2. I to E ratio. And then trigger sensitivity. Remember, trigger can be flow or pressure. So you just put the number. If it's pressure, it'll be minus. If it's flow, it'll be plus. Okay, good so far? Okay, so that's set parameters. And remember on this ventilator here, you can get some of those down here. The others are there. And sometimes you're not going to see some of them right here, but like on this one, there's a box here. This little box tells us our I to E ratio and some other things. But those are all set. So then the next session is our patient. So this is what we've set. What's actually happening is what you're going to record next. So respiratory rate. You're going to see this done a couple different ways. You can either see mandatory rate. This one just says respiratory rate. This is how many breaths the ventilator is delivering. So if we're set at 12, it should be giving 12, ideally. And then spontaneous. Now this is the thing you're going to see done differently, depending on the RT and where you're at. Let's say we have a spontaneous rate of 12, a set rate of 12, and my patient's breathing 10. Our total rate is 22. Depending on the vent check sheet or the RT, some of them will say total rate, so that would be 22. Some of them say spontaneous rate. Some RTs will put 10, some will put 22. Because some will put the total, 22. Some will put just what the patient is doing, and the two of them would equal 22. So just be wary of that, and you'll learn wherever you're at how they do it, so you'll know. If it was me with this vent sheet right here, I would do 12 and 10. I got a set rate of 12, and my patient's doing 10. Because my total rate is at 22. Tidal volume. This tidal volume, we want exhaled tidal volume. Some vents measure inhaled and exhaled. Most just measure exhaled. Now this is one thing that's important to understand. When you deliver a breath, what's our tidal volume set right now at? 450?
450.
450. So here's our inspiratory. Right here at the machine. 450 should be coming out. Exhaled tidal volume is a direct measurement of how much was actually delivered to the patient. Because if we put 450 here, 450 should go through our inspiratory limb to the patient, come back out through the expiratory limb and back to the ventilator. Does that make sense so far? Because exhaled, people think, oh, that's what the patient exhaled. It's actually, we use it as a direct measurement of what the ventilator delivered. Because if we delivered 450, if we had 450 here, we should get 450 back. So exhaled tidal volume, if this is low, it's because something happened along the way that the air didn't get to the patient. It could be something in the circuit. It could be something with the ET tube. So exhaled tidal volume is a direct measurement of are we delivering the volume that we want to give. It's one of the most important numbers that we look at on a vent. Because if we're not delivering our volume, what will that affect? You say something?
I'm saying patient's oxygenation.
Maybe, but
Ventilation.
ventilation. Remember, ventilation is our tidal volume and our rate
Can you repeat when you said exhale tidal volume is a direct measurement?
of the volume that we delivered to the patient. The amount of air that was actually delivered to the patient. So if our volume is off, it's going to affect our minute ventilation. If our minute ventilation is bad, what's going to happen to our ABGs?
Acidic?
Yeah, right? What do you say?
Acidic.
Okay, and what's going to happen to our CO2? It's going to go up because we're affecting our patient's ventilation. Oxygen may or may not, depending on how your patient's status is, but it's going to affect the ventilation. So remember, because we're going to be talking about this more, but we'll be having a little check off on settings that affect oxygenation versus ventilation. Ventilation, respiratory rate, tidal volume. Remember how we talked about those are separate, even though they're related. Oxygenation, FiO2, and PEEP. If someone's CO2 is 80 and their pH is 7.2, we don't raise their FiO2. It's not going to do anything except give them more oxygen. We need to change their minute ventilation because their minute ventilation is what's going to help with that. So here we see our exhale tidal volume. It's red down here, and it's 472. You want it to be plus or minus 100 of what was delivered, and that's how we'll set our alarms too when we get to that. So you'll put that under VT, under patient parameters. So we would put 472. It's never going to be exactly what you set. Plus or minus 100.
And that's, you said spontaneous?
No, spontaneous is actually going to be if the patient's able to take a breath on their own. You would put what their tidal volume is.
And it would be NA if you're an AC.
Yeah, exactly. And that's in mLs.
What'd you say, Anthony? NA what?
It would be NA if you were in AC, because you're going to have your patients, the machine's going to be delivering. If your patient's in SIMV, you would wait until you saw some of their own breaths, and then you would put what their own breath was, 200 or whatever their spontaneous was. So the machine exhale tidal volume would go under VT, the patient's tidal volume would go under the next one. Or if your patient's in SIMV and they're not doing anything above the rate, it would be aligned through that one too, because they're not taking any. Minute ventilation is the actual minute ventilation that's being delivered. So here we can see it's 7.0 liters per minute.
You said actual ventilation that's being delivered?
Yeah. So if our rate was 10 and our tidal volume was 600, our minute ventilation would be 6. However, if our patient was breathing 16, then your actual minute ventilation would be 16 times 600, whatever that is. So that's actually a readout. Because remember, we don't actually set a number. We don't dial in a minute ventilation. We don't dial in a number that says, I want a minute ventilation of 6.0. We set our minute ventilation by setting our rate and our tidal volume. So then we can see once we set our rate and our tidal volume is our minute ventilation about where we want it to be. And as long as it's less than 10 and over 5, you're usually okay. Patients that are very tachypnic will have a higher one, of course. Okay, PIP. PIP, peak inspiratory pressure. You will also see that listed on some vents as P peak or peak.
Could you say that one more time? What else is it listed as?
P peak or just peak, like peak pressure. And what that's saying is, can I use one of those? Can I use that green marker? Thanks. Now it'll work. P peak is the maximum pressure that's used to deliver a breath. So if it takes me 20 to get that's the peak. If you're in pressure control, it'll be the pressure that you have set plus any PEEP. So say you're in pressure control of 20 and you have PEEP of 5, your peak would be 25. You'd have to add the two together because your baseline, if you have PEEP, is not 0 anymore, it's 5. In volume control, it already takes that into consideration, so you won't have to add in. So if you're in pressure control of 20 and PEEP of 5, you should expect to see your peak pressures around 25, give or take. As a general rule, you want your PIPs to be less than 30. $35 max. Any higher than that puts your patient at risk for barotrauma. If you're in volume control and your patient has high PIPs like that, what could you do? Increase the alarm? You just gave him a pneumo.
No, decrease the volume.
I don't want you to decrease. I need his minute ventilation to stay where it is.
Decrease the pressure.
You can't. You're in volume control.
You said the pressure's too much?
His peak pressures. You're in volume control, and it's taken 35 to deliver that peak pressure at 35 to deliver that breath. The doctor wants you to do something about that because he's worried the patient's going to get a pneumo.
Lower
Could
peak.
drop the peak.
Nope, I need the peep that I have. Think about the other modes that there are, folks.
Do pressure control.
Switch them to pressure control. Your peaks are too high, you're in volume control, switch them to pressure control because now you can control their pressures and make sure we don't give them pneumos.
But you won't get the same volume.
No, you won't, but it's okay to have a lower tidal volume as opposed to a pneumo.
And you said that as a general rule, you want HIP to be less than 30
30, 35 max.
max.
Yes.
35?
Yep.
Because anything more would cause a barotrauma.
Well, puts them at risk for barotrauma. And the other thing to realize, if someone has peak pressures like that, there's something going on. Secretions, it could be just secretions. If it's just secretions, the patient needs to be suctioned and your pressures will come down. But if it's that a restrictive lung disease is happening, like ARDS, we got fluid, inflammation, things like that, and your pressures are increasing like that, your patient's getting worse. So your pressures are going to keep getting worse, which is why you want to switch them over to pressure control. Does that make sense? Mm-hmm. Okay. So that's PEEP. PEEP, actual PEEP reading is what goes here. So here our PEEP is 4. And what would cause, let's say I have my PEEP set at 4 and I have a PEEP of 10, an actual PEEP reading of 10. What could that signify?
There's an obstruction going on?
Maybe
Resistance?
That's what I was going to say, resistance. Increase resistance.
increased resistance causing what? Our PEEP reading is 4, our set PEEP is at 10. I mean, our PEEP reading is at 10.
Low compliance.
No. Air trapping. Patient's not exhaling, and so it's getting trapped in there. That's your patient who doesn't have enough time to exhale. And you'll see that, you'll also see that right here on your flow waveform, you'll see that your flow doesn't return to baseline before the ventilator gives another breath. So he doesn't have enough time to exhale, and that's reflected in and it's called auto PEEP or air trapping. So plus, plus 1 or 2 above your PEEP reading is okay. More than that, they're going to have problems. So that's when you'd have to make changes. I just bring it up because we're talking about it. Plateau pressure is a direct reflection of the pressure needed to keep the alveoli distended.
So you do the inspiratory hold.
Yes, you do an inspiratory hold.
Say that one more time. Direct reflection of.
Plateau pressure is a direct reflection of the pressure needed to keep the alveoli open and distended. It's a very important number on our ventilator, and it's a increasing plateau pressures. What did everybody get a chance to write down? I don't want to go too fast. Increasing plateaus, decreasing compliance. No, plateaus. Increasing plateaus means decreased compliance. Think of our balloon example. We have a nice big happy balloon. Doesn't take a lot of pressure to blow it up, and it doesn't take a lot of pressure to keep it open, right? Right? What happens if we get our little tiny balloon?
Takes a lot more pressure.
It takes a lot more pressure. When you think of restrictive lung disease, think of that little tiny balloon. It's going to take a lot of pressure to keep that open. So you do that by doing an inspiratory hold. You don't really measure these in pressure control. We're already controlling the pressure, so we're not as concerned about our compliance. There's other ways we can tell their compliance is changing, which we'll cover later. In volume control, you're going to do an inspiratory hold. So when the breath starts, you do a hold. And this one makes you do an expiratory hold too, but you don't usually have to do that.
You have to change what you.
And I didn't do it fast enough. There, see, I got my plateau, 27. And then usually I'll get compliance, but, so you have to go to where you can see the plateau. So our plateau's there. The breath starts, breath starts, do inspiratory hold it for just a couple seconds, you'll get your plateau and let go. Because remember, you're doing a breath hold on your patient when you do that. You don't want to do it for a long time, it'll be very uncomfortable for them. Make sense? Okay, yes.
Is the compliance one the same as the static pressure?
Static compliance is not necessarily static pressure, but we measure static compliance, which is what that plateau is for, because you have no airflow.
Okay.
So, and the next line is compliance. Time for another calculation. I gotta remember to get that big old whiteboard thing in here. So exhale tidal volume divided plateau minus PEEP is compliance. That's how you calculate it.
Tidal volume.
Divided by plateau minus PEEP. The way everyone remembers it is the word complete. COM for compliance, PL for plateau, and EEP for PEEP. Because in a minute I'm going to teach you airway resistance, and it has different pressures, and everyone confuses them. So complete. This is going to be compliance and airway resistance, you guys. You're going to have to know like the back of your hand. This is I know a lot of ventilators calculate this for you, but not all of them do, number one. Number two, if you understand what this number means, by calculating it, it helps you understand what it means when you see just the number. It's compliance and resistance have everything to do and affect our ventilation every day. It's the meat and potatoes of mechanical ventilation. Because you have to be monitoring your patient's compliance and resistance, because it will change how you ventilate them. And it will change how your ventilator breath is given, depending on changes in resistance and compliance. Because if you're in volume control, just to give some examples, and your patient has a bronchoconstriction, your pressure will go up because of increased airway resistance. If you had air going through a garden hose, everything was happy. Our patient goes into bronchoconstriction, we got a straw. It's going to take a lot more pressure, right? So you can see airway resistance, increased airway resistance, bronchoconstriction, increased pressures. We get rid of the bronchoconstriction, guess what? Airways open again, the pressures come back down. Patient is having an asthma attack on a ventilator, you're going to have pressures driving you crazy. And then what's your patient at risk for then? Barotrauma. So then decreasing compliance. We went from the nice big happy balloon to the little tiny balloon, increasing pressures, right? So same thing, if we're in volume control, our patient's compliance goes down, you'll see your pressures go up. So changes in resistance and compliance are going to affect how you ventilate them. So this is something you're not going to walk out of here and understand today, but by the time we're done to run a vent, you have to understand how compliance and resistance, number one, what diseases, as we're going to start talking about next week, have caused changes in compliance, and what are they? And how is that going to affect your ventilation of your patient? Because like when we talk about those patients that have ARDS, I know I go to that one a lot, but it's one of the best examples, because they're going to have terrible lung compliance. Their lungs are filled with fluid, red blood cells, macrophages, neutrophils, you name it, it's in there. Guess what happens to surfactant? There's no place for it. It's replaced by all that. And guess what else happens? You have some scar tissue that develops. What's happened to your lungs now? They're like ventilating a brick.
They're hard.
They are, yep. So that number will go there. So you'll take your exhale tidal volume and divide it by whatever your plateau and your PEEP is. So let's do this example. Our exhale tidal volume is 467. Our plateau was 27 and our PEEP was 4.
Plateau was what again? Sorry.
27.
And PEEP.
And exhale tidal volume?
Exhale tidal volume is 471.
31.